All right. All right. So Ilana, I'm going to turn it over to you. And then when you are done, if you have time for questions, that's great. And then we'll open it up for questions for both you and Birdie.
Okay, thank you. First of all, I'll just introduce myself. Thank you very much actually for that introduction. I'm Ilana Kirsch. I want to just start first of all by saying to Birdie that I so appreciated your talk, and I've learned a lot personally about postpartum mood disorders. Really, since I gave birth to my first child 23 years ago, and I learned something personally from you in explaining the blues that I had with my first child, which actually morphed into some of the exact examples that you gave for postpartum OCD. And I share that with all of you now. And I also often share that with my patients in an attempt to let them know that they are not alone, because I felt personally extremely alone when I was experiencing those symptoms as a new mom after having been an obstetrician for 10 years and just being totally blindsided by those symptoms. So they are common, and I definitely am living proof of that. Today we're going to talk about treatment considerations of depression and anxiety during the pregnancy and the postpartum period. This is not moving forward. Okay, just click on it. Click on the screen. All right. Okay. So I'll just offer a few learning objectives. We're going to define perinatal depression. I know Birdie already did that. Understand some common options for screening for perinatal depression. I'm going to talk a little bit about non-pharmacologic treatments, which I know Birdie touched on as well. And then we're going to discuss the safety and importance of various different pharmacologic or prescription treatments for this diagnosis. So the definition of perinatal depression. This is depression that occurs during pregnancy or in the postpartum period, which is the first 12 months after birth of the baby. As we've already heard, it affects up to 1 in 7 pregnant or postpartum women. It does not include postpartum blues, which, as you know, will resolve spontaneously without treatment within 2 weeks postpartum, and is experienced, as Birdie mentioned, across cultures by up to 80% of women. Postpartum depression is depression or postpartum mood disorders, we'll say, are symptoms that occur and last more than 2 weeks postpartum that just don't go away. Certainly, there is an increased risk in depressed patients who need medications but stop them during pregnancy. And so that is a shout out to women who need medications. They should stay on their medication. And we'll talk a little bit more about that later. Causes of postpartum mood disorders, there's likely a combination of factors. There are big changes in hormones or brain chemicals, both during pregnancy and then, of course, as things come crashing down immediately after the birth of the child. Again, as Birdie mentioned, there are genetic factors. Anybody who has a family history of depression or anxiety or other mood disorders is at increased risk of herself having postpartum or perinatal mood disorders. And then situational causes. The pregnancy itself may be the result of a surprise. As we know, 50% of pregnancies, that's not around the world, by the way, 50% of pregnancies in our country are unplanned. The rest of the world has actually a lower rate of unplanned pregnancies because they have a higher rate of effective contraception use. And I could get into that too, but I won't. I've said enough on that right now. also, women who maybe don't have the support of a partner or are ambivalent about being pregnant would be at increased risk for a perinatal mood disorder. So talking about screening considerations. The American College of OBGYN recommends that all women be screened at least once in the perinatal period using a validated tool. And we saw some of those tools on Bertie's slide. These are questionnaires. They're simple, they're short, they're easy to take. Most screening tests take 5 to 10 minutes to complete. I will put in for providers talking to your patients, for patients talking to your provider is also very important in screening. I know that every woman in delivering in St. Joseph County, in our county, is given a postpartum screening tool after she delivers. So these are a list of the common screening tests, and the Edinburgh Postnatal Depression Scale, which we saw earlier, is the test that's given to every woman that's delivering in either of the hospitals in our county. The Patient Health Questionnaire number 9, which has 9 questions on it and also is extremely easy to take and score, is also commonly used at the first OB visit in a lot of practices. And then the others that I listed here are less commonly used, but also useful. The Beck Depression Inventory has 20 questions on it. The Zung Self-Rating Depression Scale has 20 questions on it. And then the Postpartum Depression Screening Scale has 35 questions on it. For those of you that haven't looked at these tests, they are all very easily found on the internet. You can just type in their names onto your search engine and you can find a copy of any of these, and they come with instructions on how to score them. So they're very easy to score. Now, the importance of treatment. I cannot overstate the importance of treatment of some sort for those who need it. Untreated perinatal depression and anxiety is associated with poor outcomes, both for the baby and for the mother. Poor outcomes may be due to not taking care of oneself as well as one can, not resting enough, not eating a good diet, not exercising enough, and not getting adequate OB care because of just lack of motivation to establish or go to appointments. Specifically, poor outcomes include a risk of preterm birth, low birth weight, or intrauterine growth restriction, obviously difficulty bonding with the baby, and behavioral problems during infancy and childhood, which can be lifelong. So these are really serious outcomes, poor outcomes for women who need treatment and don't get it. And it's our job as healthcare providers to make sure that we are getting women the help that they need and identifying who is at risk and who needs help. Briefly, I'm going to talk about non-pharmacologic treatment. Various types include cognitive behavioral therapy, that is talking with a licensed therapist to help manage negative thoughts by changing your way of thinking or not thinking about the stressor that you are having. That stressor may be pregnancy, it may be something else, but talking through that to feel better about the stressor. There is also interpersonal therapy, again with a licensed counselor or therapist, which helps to identify and deal with problems in your personal life which are causing stress and managing that stress better. And then, of course, support groups, of which we saw tons and tons of support groups, and those are obviously very helpful for a lot of women, both people who are having therapy at the hands of a trained professional, but also there are a lot of not just women, there are a lot of people, obviously, who are either unable or unwilling to seek professional help. And in that case, guiding them into an appropriate support group would be very helpful. So pharmacologic treatment, 80% of women take at least one medication of any type during pregnancy. I'm talking about even Tylenol, beyond just prenatal vitamins, including Tums for indigestion, including just all kinds of over-the-counter medications. So when we're talking about the risks of actually taking a medication in pregnancy, it does make it hard to assess the impact of just a single compound on maternal and fetal outcomes, because there could be confounding factors related to other things that people are taking, some of which could be psychoactive medications, various herbs that people think because it's an herb, it's safe, and it's not necessarily, or may have some kind of interaction with other things that they're taking. Okay, so impact of antidepressants on birth outcomes. First of all, I want to talk about, I want to remind you, keeping in mind that untreated depression and anxiety has adverse effects. There are questions about whether being on some antidepressants may have adverse effects as well. The question of miscarriage has not been clearly shown. Is there an increased risk of miscarriage using antidepressants or anti-anxiety medications? Not clearly shown in a number of studies. Is there an increased risk in low birth weight babies? Again, not clearly shown, and just a reminder, that was also a risk of untreated depression. Preterm birth, same thing. Again, in some studies, there has been a link to preterm birth in women on antidepressants. But again, as we saw earlier, preterm birth is a risk in untreated depression. This is a little bit more serious. There has been a question of structural malformations, a question of heart problems developing on women on Paxil or paroxetine in some but not all studies. And so knowing that Paxil is probably not the best drug to use, certainly not as a first choice for treating mood disorders. And then what's more common, neonatal behavioral issues. And this is called poor neonatal adaptation. It usually resolves within 2 weeks. It includes jitteriness, a weak cry, some low blood sugar issues or increased respiratory rates. And this is similar to babies who are weaning off of nicotine addiction because their mothers smoked cigarettes during pregnancy. It's transient and doesn't have any long-lasting effects. And then finally, a rare condition called persistent pulmonary hypertension of the newborn. And this has been studied and published on very extensively recently. And I'll talk a little bit more about this, but it's a rare complication and can happen in the absence of medication, but is slightly more common with certain antidepressants. So I'll talk about those in a second. But this, I want to just point out, is something that women, ask me a lot, and maybe ask all of the caregivers in this audience a lot about. There are no long-term behavioral effects on children of mothers who took antidepressants in pregnancy. So no difference in behavior, cognitive function, or temperament of children exposed to medical treatment in utero compared to children of non-depressed mothers. And I think that is something that's very important to share with women, to allow themselves, to give themselves permission to get the medical treatment that they need if they need medical treatment. So talking about various antidepressants, Obviously, as I mentioned, some are safer than others. It is best to use just one if possible. There will always be fewer side effects or fewer effects on the pregnancy if only one medication is needed. I always counsel patients, do not just discontinue your medication until you talk with your caregiver about it, and that caregiver is your obstetric caregiver and also your mental health caregiver, if you have one. These drugs are also used to treat anxiety. So of course, when we're talking about perinatal mood disorders, it's not just depression, as we discussed earlier, it's also anxiety, and some antidepressants also help with anxiety. Antidepressants are divided into a number of different classes. I've grouped them into kind of 4 sections here. Selective serotonin reuptake inhibitors. These increase the level of serotonin in the brain. Serotonin norepinephrine reuptake inhibitors, or SNRIs. These increase levels of serotonin and norepinephrine in the brain. Wellbutrin and tricyclic antidepressants, and they also increase serotonin and norepinephrine in the brain and decrease acetylcholine. So SSRIs are definitely the most commonly used. They're the ones that we hear about the most. Here's a list of them. And I've listed them in order of what I see as the best safety profile. So Zoloft, if a patient will tolerate Zoloft and get well or get better on Zoloft, is going to be my drug of choice for treating a perinatal depression, or if a patient comes to me wanting to be pregnant but has depression and anxiety, Zoloft will be the first drug that I offer her. And also Celexa, which has a similar safety profile, and then on down. Going back to the persistent pulmonary hypertension of the newborn, this is a very rare but serious problem in untreated women, in women who are not on an antidepressant. 0.2 to 2 per 1,000 women will give birth to a baby affected by this disorder. In women on an SSRI, 3 to 6 per 1,000 will have an affected baby. The risk is lowest with Zoloft. So it's pretty close to 2 to 3 per 1,000 with Zoloft. Again, while this is a serious complication, it's still extremely low in incidence. And so even if it is 2 to 3 times increased risk, 2 to 3 times a very low number is still a very low number. SNRIs are Effexor, or venlafaxine, and Cymbalta, which is duloxetine, and these may be increased. These may be associated with an increased risk of gestational diabetes. And then the less commonly used antidepressants in pregnancy are Wellbutrin or bupropion, which may be associated with an increased risk of miscarriage or heart defects, and then tricyclic antidepressants, including Pamelor, which is nortriptyline, and Elavil, or amitriptyline. And these may be associated with an increased risk of anomalies, including heart defects. And I do not see these commonly used in pregnancy for that reason. I'll just close with a summary of what we'll call best practices in treating perinatal depression. First of all, I would encourage my patients to talk with their obstetric caregiver, me, whoever they're seeing, before pregnancy to optimize treatment. If they need to be on medication, be on the safest medication as tolerated. If they need to stay on medication, stay on it and not stop it abruptly without the doctor's care. And as we know, abruptly stopping medication for mood disorders causes a very, very uncomfortable and sometimes dangerous rebound of symptoms. Consider changing to a treatment with the best safety record in pregnancy if tolerated. I have patients who have tried to wean off of whatever was working for them and onto Zoloft and just didn't feel well on Zoloft and had to go back to what was working for them. And it's important to individualize, talking about what works best for an individual patient and the risks of untreated depression in her if she can't tolerate the drug that has the better safety profile. She at least needs to be mentally healthy, and that is an important discussion to have with each individual patient. And trying to limit the number of different medications used as needed to control mood disorders. And then encouraging patients to get good OB care, attend all the OB visits, and to, because that is what's going to help give you and, the patient and her baby the best chance for good health in the long term. And that is all I have. So I'll go to questions and
So we do have some questions for you.
okay, I'll just stop the screen share then.
Sure. Okay. So the first question is, it's so important to know this information about the safety of antidepressants versus THC use, which is beginning to show an impact on fetal brain development and child's neurological development later. Can you comment on that?
I have a fantastic article on my desk in my office where I am not sitting right now about that very topic. But there was an article that I just read literally in the past month that looked at long-term effects of marijuana or THC use, long-term effects on the baby. And there was a significant, I cannot remember the exact number, but a significant percent of school-age children issues in children who had been exposed to marijuana in utero. And so I cannot say strongly enough, and the American College of OBGYN has a position statement on this as well. Marijuana is unsafe. It is dangerous in pregnancy. In states where it is legalized, and I'm guessing that eventually in this country it's going to be legal throughout the country, there are increasing rates of use in pregnancy. There have been studies, I did read a study where researchers called up marijuana dispensaries posing as a pregnant woman with first trimester nausea and asked questions of the person answering the phone. I'm having nausea, I'm pregnant. Is it okay for me to use marijuana to alleviate my nausea? And they were told over and over again, sometimes with a disclaimer, I'm not a doctor, but usually, oh yes, it's definitely going to help. It's all natural and it's really okay. And you know what? It's really not okay because there are long-lasting effects for the child in terms of school performance and behavioral issues in the school. I saw some, as I was talking just now, I saw some messages come up regarding that article. I will, once I get to my office next week, Lisa, I will send you a link to that article and then you can share it with the participants.
Sounds great. Okay, let me ask you this other medication question, and then we'll bring Bertie on, and then I want to take a break by 10:20. But here's the question for you specifically, Dr. Kirsch. The person asking the question was curious about why Prozac was below Paxil on that slide that you showed where you listed the SSRIs, Zoloft.
I might have gotten those switched, so probably I should have done that in the opposite direction.
Okay, great. Thank you for clearing that up. Okay, so Bertie, if you want to come on, let's see if there's other questions for both of you. There was one question about the use of prenatal vitamins and good nutrition and whether those have an effect on preventing postpartum depression. And what about continued use of prenatal or hormones after birth? So either one of you, do you have any thoughts on that?
I mean, I'll just say that prenatal vitamins are recommended throughout the postpartum period. So prenatal vitamins, I always tell my patients, should not just be called prenatal vitamins. They should be called preconceptual, prenatal, and postpartum and breastfeeding vitamins. I tell all my patients that they should stay on a prenatal vitamin as long as they are breastfeeding and anytime they may become pregnant. I believe there is some thought in certain studies that just taking a daily multivitamin can help with mood disorders generally, like PMDD. And and so there's definitely no downside, I think, to taking a multivitamin or a prenatal vitamin every single day for every woman. And I do encourage patients to do that. In terms of having a better diet, I'm not aware of how diet would play a role in affecting mood. Obviously, mood can play a role in what you choose to eat or not eat, but I'm not sure how eating certain foods would help
Bertie, do you have
affect your
any?
mood.
Yeah.
Um, yeah, I go along with Dr. Kirsch with all of that. There are studies to show, I mean, I think the studies make me laugh when I see that we really did studies, but eating a healthy diet is better for us than eating an unhealthy diet. And so eating, honestly, there was a study, we have it in our 2-day training, that they studied people who ate great diets, and then they studied people who ate, and it tells what they had them eat, you know, fried foods and blah blah blah, and showed that mental health is better when we eat healthy. We all know that. That's kind of logic. Same with exercise. Many studies have, not just exercise, going for a walk, moving, not being sedentary, those are all preventive factors. Doesn't mean you won't still get postpartum depression, but continuing, like Dr. Kirsch said, I always say, keep taking your prenatal vitamins. And really, a lot of postpartum women are surprised. Oh, I didn't realize I was supposed to keep taking it. You have to really remind them, keep taking that. But if part of that question is, does hormone treatment work? Because I read the question afterwards. We have lots of studies. People always think, well, this should be a real simple fix. Let's just do some hormones because this is a hormonal change. Uh, Studies are not really showing that there's any effect of giving certain hormones postpartum. That doesn't really help, but always good, good self-care, good eating, moving, walking. I don't like to use the word exercise because it makes you think you're lifting weights and, you know, doing it all. I just tell new moms, get out there and go for a walk, put the baby in the stroller. Getting sleep, which is really hard as new parents, but those things, that good self-care, asking for help, those are all the things that help us along with possibly needing medication.
And
That's great.
let me just add in also, though, just to piggyback onto what Bertie just said. There, last year, a new treatment for severe postpartum depression was approved by the FDA, and I believe it's called brexanolone. It's a progesterone that is a female hormone. It is given intravenously in an inpatient hospitalized setting. It requires, I think, 2 to 3 days of hospitalization. It costs something like $30,000. However, it has been shown to be highly effective in cases of severe and refractory postpartum depression. So for select women, that is a very important treatment. But just taking progesterone in other forms, that's not necessarily a known treatment.
Okay. So it is 10:20